Welcome to our comprehensive review of sacroiliac SI joint injury, a condition that is both common and frequently overlooked in the world of chronic low back and pelvic pain. The SI joint acts as a crucial bridge between your spine and pelvis, handling significant biomechanical stress every day. Despite its importance, SI joint dysfunction is often underdiagnosed, mainly because its symptoms can mimic those of lumbar spine or hip disorders. In this video, we'll explore the anatomy, causes, diagnosis, and management of SI joint injuries, helping you understand why this joint is so vital to your overall mobility and comfort. Let's begin by understanding what makes the SI joint unique. Sacroiliac joint is the only synovial joint connecting the axial skeleton to the lower limbs. It's designed to transfer loads between your upper body and legs, allowing just a small range of motion, typically less than 4 degrees of rotation and 2 millimeters of translation. This limited movement is intentional, providing stability while still permitting enough flexibility for walking, lifting, and twisting. The SI joint structure combines dense ligaments with a fibrosynovial articulation, making it both strong and slightly mobile. This unique setup is what allows the SI joint to withstand the daily forces placed upon it, but also what makes it susceptible to injury. SI joint injuries are implicated in up to 30% of chronic mechanical low back pain cases, yet they often go unrecognized because their symptoms overlap with other conditions like lumbar disc problems or hip disorders. The SI joint's role in transmitting forces means that any dysfunction can lead to significant pain and mobility issues. Recognizing SI joint injury is essential for effective treatment, as misdiagnosis can result in prolonged discomfort and unnecessary interventions. Understanding the prevalence and impact of SI joint dysfunction sets the stage for exploring its causes and how to identify it accurately. Causes of SI joint injury are diverse and often multifactorial. Trauma is the most common, accounting for nearly 88% of cases, whether from high-energy events like car accidents or repetitive microtrauma in athletes. Pregnancy is another major factor, as hormonal changes increase ligament laxity, making the joint more mobile and prone to pain. Degenerative osteoarthritis and inflammatory arthropathies, such as ankylosing spondylitis, also play significant roles. Even anatomical variations, like leg length discrepancies or muscle imbalances, can predispose someone to SI joint dysfunction. Recognizing these risk factors is key to both prevention and targeted treatment. Traumatic injuries to the SI joint can result from sudden, high-energy impacts like falls or car accidents, or from repetitive stress in sports. These injuries are classified based on the direction and type of force involved: anteroposterior compression, lateral compression, or vertical shear. Each type affects the joint and surrounding ligaments differently, leading to varying degrees of instability and pain. In athletes, repetitive twisting and loading can cause microinstability, while in severe trauma, the joint may be disrupted entirely. Understanding the mechanism of injury helps guide both diagnosis and management strategies. Pregnancy introduces unique stresses to the SI joint. The hormone relaxin increases ligamentous laxity, allowing the pelvis to widen for childbirth. While this adaptation is necessary, it also makes the SI joint more vulnerable to hypermobility and pain, especially in women with multiple pregnancies or those experiencing rapid labor. The added weight and changes in posture further strain the joint, often resulting in pelvic girdle pain that can be more disabling than typical back pain. Fortunately, most pregnancy-related SI joint pain resolves postpartum, but understanding this risk can help with early intervention and support. Degenerative osteoarthritis is a frequent culprit in SI joint dysfunction, especially as we age. The joint space narrows and bone spurs can form, leading to pain and stiffness. Inflammatory conditions like ankylosing spondylitis cause even more dramatic changes, including joint erosion and eventual fusion. These diseases often progress over time, with symptoms like morning stiffness and pain that improves with activity. Early detection and appropriate management are crucial to prevent long-term disability. Recognizing the signs of both degenerative and inflammatory SI joint disease is essential for effective care. Certain anatomical and postural variations can increase the risk of SI joint dysfunction. Exaggerated lumbar lordosis, anterior pelvic tilt, and leg length discrepancies all alter how forces are transmitted through the pelvis. Weak core or pelvic muscles can further destabilize the joint, making it more susceptible to injury. These factors are particularly important in individuals who are sedentary or have poor posture, as well as those with neuromuscular imbalances. Addressing these underlying issues through targeted therapy can help prevent SI joint problems before they start. SI joint dysfunction is more common than many realize, contributing to 15–30% of chronic low back pain cases. Prevalence varies by age and population, with higher rates seen in trauma patients and pregnant women. Interestingly, up to 20% of asymptomatic adults show abnormal SI joint motion on imaging, highlighting the complexity of diagnosis. Surgical intervention is rare, reserved for the most severe or refractory cases, but when needed, it can provide significant relief. Understanding the epidemiology helps clinicians maintain a high index of suspicion for SI joint injury in patients with persistent back or pelvic pain. Patients with SI joint dysfunction often describe deep, aching pain in the lower back, buttock, or posterior pelvis. The pain may radiate to the thigh, groin, or even the knee, sometimes mimicking nerve-related conditions. Activities like prolonged sitting, stair climbing, or transitioning from sitting to standing can worsen symptoms. In women, pain may intensify during menstruation due to hormonal effects on ligament laxity. Recognizing these characteristic pain patterns is a critical first step in distinguishing SI joint dysfunction from other causes of back pain. Thorough physical exam is essential for diagnosing SI joint dysfunction. Key maneuvers include the Giensland's test, which stresses the SI joint through hip extension, and the Faber-Patrick's test, which can localize pain to the joint. Thigh thrust and compression tests apply direct load, reproducing symptoms if the SI joint is involved. When 3 or more of these tests are positive, diagnostic accuracy improves significantly. However, because SI joint pain often overlaps with lumbar or hip pathology, these tests must be interpreted in the context of the patient's overall presentation. Imaging plays a crucial role in evaluating SI joint pathology. Plain radiographs are often the first step, providing a basic overview of joint space and alignment. However, their sensitivity is limited, especially in early disease. Magnetic resonance imaging, MRI, is the gold standard for detecting both inflammatory and structural changes, such as bone marrow edema or erosions. Computed tomography, CT, offers detailed views of bone, but is less helpful for early inflammation. Nuclear medicine scans can identify active inflammation, but are used less frequently. Always, imaging findings must be correlated with clinical symptoms for accurate diagnosis. MRI has revolutionized the diagnosis of SI joint disorders, especially for early detection of inflammatory changes. It can reveal bone marrow edema, erosions, and enthesitis, features that may not appear on X-rays for years. However, MRI is not without limitations. False positives can occur, particularly in patients with mechanical low back pain. Therefore, MRI findings should always be interpreted alongside clinical history and physical examination. This approach ensures that treatment targets the true source of pain, avoiding unnecessary interventions. CT scans provide excellent detail of the SI joint's bony structures, making them ideal for detecting fractures, erosions, or cortical irregularities. They are especially useful when MRI is contraindicated, such as in patients with pacemakers. Nuclear medicine techniques, like SPECT-CT, can localize areas of increased metabolic activity, suggesting inflammation or infection. However, these modalities are typically reserved for complex or unclear cases, as they are less sensitive for early inflammatory changes compared to MRI. Imaging and physical exams are inconclusive. Diagnostic injections become the gold standard for confirming SI joint pathology. Under fluoroscopic or ultrasound guidance, a local anesthetic is injected directly into the joint. If the patient experiences significant pain relief, typically over 75%, the SI joint is confirmed as the pain source. This technique is especially valuable in patients with overlapping symptoms or equivocal imaging findings, ensuring that treatment is appropriately targeted. Laboratory tests are important when inflammatory sacroiliitis is suspected. Markers like erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, can indicate systemic inflammation. HLA-B27 testing supports the diagnosis of ankylosing spondylitis, while blood cultures may be necessary if infection is a concern. These tests help differentiate between mechanical and inflammatory causes, guiding the choice of therapy and referral to appropriate specialists. Most SI joint injuries respond well to conservative management. First-line treatments include nonsteroidal anti-inflammatory drugs, NSAIDs, for pain and inflammation, along with targeted physical therapy to strengthen core and pelvic stabilizer muscles. Pelvic belts or braces may provide temporary support, especially in pregnancy-related cases. Patient education on posture, lifting techniques, and weight management is also crucial. These strategies not only relieve symptoms, but also help prevent recurrence. Physical therapy is a cornerstone of SI joint injury management. Therapists focus on strengthening the transversus abdominis, oblique muscles, gluteals, and other pelvic stabilizers. Neuromuscular re-education and proprioceptive training help restore alignment and reduce strain on the joint. Flexibility exercises and manual therapy can further enhance mobility and comfort. For many patients, a tailored rehabilitation program leads to significant improvement and long-term relief. Inflammation is a major factor. Pharmacologic therapies extend beyond NSAIDs. Disease-modifying antirheumatic drugs, DMARDs, and biologic agents, such as TNF-alpha inhibitors, are used to control systemic disease and prevent joint damage. These medications are especially important in conditions like ankylosing spondylitis, where untreated inflammation can lead to permanent fusion and disability. Close monitoring by a rheumatologist ensures optimal outcomes and minimizes side effects. Patients who do not respond to conservative measures, interventional procedures offer additional relief. Image-guided corticosteroid injections can reduce inflammation and pain, especially in degenerative or inflammatory arthritis. Radiofrequency ablation, RFA, targets the nerves supplying the SI joint, providing intermediate-term pain relief. These procedures are minimally invasive and can be repeated if necessary, but are generally reserved for cases where other treatments have failed. Surgical fusion of the SI joint is considered only for chronic, treatment-resistant cases. Minimally invasive techniques using triangular implants have shown promising results, with over 80% of patients experiencing significant pain reduction and improved function. However, surgery carries risks, including infection and the need for revision. Accurate diagnosis, confirmed by diagnostic injection, is essential before proceeding to surgery, ensuring that only appropriate candidates undergo this intervention. SI joint pain can mimic many other conditions, including lumbar disc herniation, spinal stenosis, hip osteoarthritis, and even piriformis syndrome. Inflammatory diseases like psoriatic arthritis or systemic conditions such as Behçet's disease must also be considered. Infectious sacroiliitis, though rare, is a critical diagnosis in febrile patients. Thorough evaluation, including imaging, lab tests, and physical examination, helps distinguish SI joint dysfunction from these other causes, ensuring accurate and effective treatment. Outlook for SI joint dysfunction is generally positive. Over 75% of patients achieve significant improvement with conservative therapy alone. Pregnancy-related SI joint pain usually resolves after childbirth, while traumatic injuries may take longer depending on the extent of ligament or bone damage. Only a small percentage of cases require surgical intervention. Early recognition and appropriate management are key to preventing chronic pain and disability. Most patients recover well. Complications can occur if SI joint dysfunction is not properly managed. Chronic pain may lead to disability, gait disturbances, and reduced quality of life. Persistent dysfunction increases the risk of opiate dependence and psychological issues like depression. Inflammatory forms, if untreated, can progress to ankylosis and systemic complications. Recognizing and addressing these risks early is essential for optimal patient outcomes. Optimal management of SI joint dysfunction relies on a multidisciplinary approach. Primary care physicians coordinate initial evaluation and conservative care. Physical therapists design individualized rehabilitation programs, while pain specialists and interventionalists perform targeted procedures. Radiologists provide diagnostic clarity, and rheumatologists manage systemic inflammatory conditions. Surgeons are involved for refractory cases requiring fusion. This collaborative model ensures comprehensive, patient-centered care and the best possible outcomes. Educating patients about the SI joint's role and risk factors empowers them to take an active role in their recovery. Instruction on posture, ergonomics, and proper lifting techniques can prevent recurrence. For pregnant women, anticipatory guidance about pelvic girdle pain and self-management strategies is especially valuable. Encouraging regular physical activity and weight management further reduces the risk of SI joint problems. Patient education is a cornerstone of both treatment and prevention. Staying physically active is one of the best ways to maintain SI joint health. Regular exercise strengthens the muscles that support the pelvis and spine, improving stability and reducing the risk of injury. Activities like walking, swimming, and targeted strength training are particularly beneficial. For those recovering from SI joint injury, gradual return to activity under professional guidance ensures safe and effective rehabilitation. Recent advances in imaging and interventional techniques have greatly improved outcomes for patients with SI joint dysfunction. MRI allows for earlier and more accurate diagnosis, while minimally invasive procedures like radiofrequency ablation and fusion offer new options for those with persistent pain. Ongoing research continues to refine these approaches, ensuring that patients receive the most effective and least invasive care possible. Recap: SI joint injury is a significant but often underdiagnosed cause of chronic low back and pelvic pain. Its multifactorial etiology includes trauma, pregnancy, degenerative changes, and inflammation. Accurate diagnosis relies on a combination of clinical evaluation, imaging, and diagnostic injections. Most cases respond well to conservative management, but interventional and surgical options are available for refractory cases. Team-based care and patient education are essential for optimal outcomes. Conclusion: sacroiliac joint injury is a complex but manageable condition when recognized early and treated appropriately. Advances in diagnosis and therapy combined with a multidisciplinary approach, have greatly improved patient outcomes. If you or someone you know is struggling with persistent low back or pelvic pain, consider the SI joint as a possible source and seek comprehensive evaluation. With the right care, most patients can achieve lasting relief and return to an active, healthy life.